Thank you, Dr. Piasecki. So along the same lines as Professor Maroof, I'm here to talk to you about a vulnerable population within a vulnerable population. So if you think about the population of people with disabilities, I'm here to talk about people with intellectual and developmental disabilities. So let's just briefly, just to frame the discussion a little bit, because the spirit of it for me is a little more of a discussion with you. First, want to talk about the special healthcare needs of intellectually and developmentally disabled. Learn about the 4 main barriers in healthcare that have been identified for people with intellectual and developmental disabilities. And then finally, all of it's exciting, but maybe the most exciting part to learn about, because we're raising awareness today, right? That's what we're all doing, is to explore some ways to improve healthcare outcomes for the intellectually and developmentally disabled. So we can talk a little bit about some of the stuff that's underway that we're working on. Okay, so special healthcare needs. So when compared to other Americans, individuals with developmental and intellectual disability demonstrate the following: lower rates of preventative care, like going and getting their flu shot every year, underdiagnosis of chronic conditions such as diabetes and high blood pressure, and finally, greater obstacles in attaining their full health potential. So why is that? Well, let me back up a minute. What are intellectual and developmental disabilities, right? How would you define that? So significant limitations in intellectual functioning, like reasoning, learning, problem solving, okay, so we've got a sense there. And some issue with adaptive behavior. Well, that covers a range of things, social, practical skills. Developmental disabilities manifest by definition before age 22. They include conditions like autism, epilepsy, cerebral palsy. Intellectual disabilities are often grouped with developmental disabilities. An example would be someone who's had a traumatic brain injury, and that can occur at any age, as we all know. Things that, how we would define that would be any impairment in mental or physical functioning, daily functioning in three or more areas, such as self-care, expressive language, or mobility. So hopefully that gives you kind of a working definition, a context for this. Okay, so now that we have that, let's think about it a little bit. Individuals with intellectual and developmental disabilities face challenges interacting with, understanding first their health problem in the first place, interacting with the healthcare professional to tell them about it, and then finally receiving that message about what to do, their treatment, and to comply, if you will. That's a term we use, right? But it maybe not the best, but it's what we ask people to do. Okay, so cognitive and communication aside, we also have some other issues that have come along since. It's about accommodations, how we help people access health care, in particular with all the changes that are going on right now that we're all seeing with the Affordable Care Act and changes in health systems. So if you take a quick look at the Behavioral Risk Factor Surveillance System, or also known as the BRFSS, some of you might be familiar, okay? So most recent data you can find for Nevada is 2012. It's a questionnaire. It's a questionnaire that's used for surveillance on behavioral and chronic conditions for the population. There's 2 questions dedicated to disability. The first one essentially asks adults how much if any of them are limited in activities because of physical, mental, or emotional problem. So of the population in Nevada, the respondents, 19% said they had some limitation in their activities because of some form of a disability, physical, mental, emotional, and problem loosely termed. The other question with disability, which will hinge back to where I was just talking about, is what percentage of people have health problems that require the use of special equipment? And to that, the respondents who were affirmative that said they needed some sort of special equipment like a wheelchair, assistive device like a cane, a walker, was just over almost 8%, 7.7%. So we know there's people who have these needs, and it's a matter of making sure we're accommodating those needs. Okay, so that's an issue. The other thing that we know when we look at all the data that's out there, there's been some U.S. Surgeon General reports. 2002 was a landmark one, updated recently in 2009, highlighted huge shortfalls in meeting this population's healthcare needs. How so? Well, firstly, we have a shortage of qualified trained healthcare professionals. Okay, well, you've heard this before, but specifically in treating and caring for these individuals with intellectual and developmental disabilities, especially trained to meet their needs. The people who face this the worst are the ones who live in the inner city and rural areas. Secondly, the need for comprehensive mental health, ophthalmologic, and dental programs due to low numbers of dental care, PAP screenings, immunizations. Another finding, doctors, negative attitudes towards patients with intellectual and developmental disabilities, right? Looking at the patient's roles in the healthcare is very limited, that, they don't really have much of a decision-making process here that obviously influences care. And finally, a number of individuals with developmental and intellectual disability are of low socioeconomic status, placing them oftentimes on public insurance systems such as Medicaid. What we do know is a lot of doctors don't like to subscribe to Medicaid for a number of reasons, or limit their patient panels because of fears about inadequate compensation and increased administrative costs involved with caring for this population. So that's another potential barrier to getting the care that they need. Okay, so we're putting it all together. These are some hypotheses of why maybe we aren't meeting the same health, achieving the same health as others. So, to formalize it a little bit more, great focus group study that looked at this in what's known as the medical mecca of the world, Boston, Massachusetts, right? Doctor on every corner, right? Public health, everything, wonderful. Okay, so they met with parents, family members, patients, healthcare professionals, and of people with intellectual and developmental disabilities, and tried to answer this question of why is this happening? And this was done by Ward, Nichols, and Friedman in Health and Social Work in 2010. And come see me if you want the reference specifically. But these were the themes that came out of the focus groups. And I'm just going to give you a quote from each of those representative constituents as we go through them. Problems with the four main barriers were access, knowledge, communication, and quality. So access. Problems finding the healthcare providers. Okay, I alluded to this a little bit, right? Finding someone qualified, finding the right person for their son or daughter or for that individual. Okay, specific problem, transitions of care. Patients remaining with pediatricians until they're in their 20s, 30s, 40s. There's a range reported in the literature, age range 27 to 40 is the age of transition for an intellectually or developmentally disabled adult to go from pediatric care to someone trained to treat adults. Well, what does this mean? This means that someone might not be getting the age-appropriate screenings and care that they need. Okay. So, and then the other issue with access is a lengthy wait. If there aren't a number of providers out there to treat this person, they're going to spend a lot more time in the waiting room, which, we all know how that feels. Okay, so let me give you a quote from a healthcare professional. Quote, "We get patients with intellectual developmental disability referred to us. The hospital has a huge adult congenital heart team. Patients are kept here into their 30s and 40s. It's unrealistic for pediatric dentists who really specialize in 3-year-olds and 6-year-olds to see someone who's in their 40s. There are adult problems, adult gum problems." So the point being, we're not doing the best we can. We're not doing anyone any service by keeping them on longer than we should. Okay, so that's access. How about knowledge and communication? So knowledge, healthcare providers with a lack of sufficient training and exposure. So I'm going to give you a quote from a parent. This is about an internist. "He's a real nice guy, but I don't think he does such a great job. He never puts my son on the table. When I go to the doctor, they say, get undressed. He never does that, ever, with my son. He just kind of does his vitals and asks me questions, or my husband questions, but he doesn't give my son a really good physical. I don't think he really knows what to do." That's sad, right? Okay, what about bias, negative attitudes, right? That might play into our communication side of this. So healthcare professionals thinking that the person really doesn't play that great of a role, not talking directly to the patient, talking around to others. This is a quote, this is my last quote for you. This is a quote from an intellectually disabled, developmentally disabled individual. "They figure I can't talk, I can't write, So they look at the other person, and they shouldn't, because I'm just like everyone else in this room. Okay, lastly, quality. So I mentioned a few times, the lengthy wait, the rushed healthcare practice atmosphere. You've seen it, we've all seen it. Well, it's even harder for someone with intellectual and developmental disability. Some of these individuals have pretty significant behavioral issues, and to be in a waiting area, which can then exacerbate these problems, can be very problematic. So that's just adding to the problem already. Patients waiting, and then the problem escalates. Then the issue of being rushed, only having 15 minutes, having doctors tell them, well, we've got 15 minutes to cover all your problems, so let's do this. Not gonna happen, right? So rethinking that system. And lastly, maybe worsely, is when someone's behavior is just not manageable for the doctor, and the doctor feels that, they're just not equipped or they can't handle it. So instead of dealing with it or treating the person, they send them on to the emergency room, because they can take care of it there. They can sedate them or do whatever they need to do and, take care of it. Someone else's problem. That impacts the quality of care. All right, so how do we make it better? That's what I'm here to end it on. And I've listed all these possibilities because that's the big picture, pie in the sky approach. I'll tell you what we're working on right now. But definitely a community-based one is where we want this to be, linking up organizations for the developmentally and intellectually disabled with our healthcare providers, so it doesn't become this haphazard, will you take so-and-so? Will you do his dental cleaning for us, please? Will you see him for a physical? We don't want it to be that kind of atmosphere. We want it to be supportive of these individuals. Expertise, we've got it. It's in this room. It's all around. We have academic institutions, centers of excellence that are up and coming. We need to take better advantage of them. And we need to teach our rising healthcare professionals how to treat our patients better too. So we can do that through curricular changes, but also healthcare changes with the way in which our care is delivered in the systems. Self-advocacy and health advocacy for family members. Classes teaching people how to advocate for their own rights. And finally, measuring and improving health outcomes. And that's a big part of what we've started working on. We've built a proposal for a consumer-driven health promotion program. So getting the individual and their family involved in this, doing a survey, the Family Quality of Life Survey, which has a special version for people with intellectual and developmental disability, and talk to them about all these things we know are bad, but now I'm putting on the local level and saying, how can we make it better? And at the same time collecting that data, so then we can have a database, which we don't, which is scarce. If you look around, we can't find this kind of information about people with intellectual and developmental disability. So we start somewhere. We start small, but then we go big. And that's what we're doing, and I'm happy to be here to talk to you about that today, and I look forward to meeting new people to do this work with. So with that, I'll leave it there. Thanks.